Welcome to the Immunology Lecture Series for Step 1 USMLE Boards for Falcon Physician Review. My name is Nathan York. I have a PhD in Immunology from UT Southwestern Medical Center, and I will be your instructor for this lecture series. Let's begin with a general overview of immunology. So when you think of the immune system, the first thing that comes to mind is defense against pathogens such as viruses and bacteria. But on a broader sense, the immune system is a much more complex interaction of specialized cells and proteins dedicated to identifying self from non-self. Now, non-self we typically identify as microbes such as viruses, bacteria, fungus, or parasites, but we also include in this subset things like altered self proteins from cancer. This function of the immune system is called immune surveillance. Now, discrimination between self and non-self and subsequent actions are accomplished via two branches of the immune system, the innate or natural immune system and the adaptive or acquired immune system. These two subsystems often cooperatively interact to achieve immunity. Innate immunity is further broken down into cellular and non-cellular components. The cellular components for innate immunity consist of macrophages, granulocytes such as eosinophils, basophils, and mast cells, and natural killer cells. The non-cellular component or chemical component consists of chemicals such as complement, which is a cascading series of proteins used to poke holes in cells, other chemicals such as hydrochloric acid and lysozyme, and cytokines. The characteristics of innate immunity are that it is involved in the immediate response. The response is nonspecific, meaning that there's no memory, and it is invariant response per exposure. On the other side, we have the adaptive immunity. Adaptive immunity is broken down into two different subsets, the humoral subset and the cell-mediated subset. The humoral subset involves T cells, B cells, antibodies, complement, and cytokines. The cell-mediated subset is more focused, involving antigen-presenting cells and T cells. You will notice that both complement and cytokines are a part of both innate and adaptive immunity, and there we see the crosstalk between the two arms of the immune system. The characteristics of adaptive immunity, in that they differ from the innate immunity, are that they require days to develop, a primary adaptive immune response taking anywhere from 4 to 7 days to get started. The response is specific versus a non-specific response of innate immunity. And the adaptive immune response is an enhanced response on repeat exposure. Again, this goes back to the idea of memory, which we will discuss later. In this slide, we have an overview of hematopoiesis, which takes place in the bone marrow. Now, you note that this is a very busy slide, and it won't be required for you to memorize all of the different sets and steps that you see in this slide. However, there are some important things that you need to know for the boards. Starting in the top left with the pluripotent stem cell. This is different than the embryonic stem cell that you hear about talked in the news all the time. That would be a totipotent or omnipotent stem cell, and those stem cells can regenerate into any type of tissue in the body. However, this stem cell is pluripotent and doesn't have quite the totality that those cells have. This is called a hematopoietic stem cell, which you may have heard about in context of bone marrow transplants. This pluripotent stem cell or hematopoietic stem cell is capable of being regenerated into any type of blood cell that comes from the bone marrow. For immunology, we're just going to focus on the myeloid and lymphoid lineages of this cell and not the thrombocytic or the erythroblastic forms. So as we go from left to right, you'll see that this pluripotent stem cell goes through progenitor steps into both myeloid progenitors and lymphoid progenitors. Continuing on with the lymphoid progenitor, this cell further differentiates into three different types of cells, the B cell, the NK cell, and the T cell, which are all lymphocytes, and that's where they get their name from. Going the other direction through the myeloid progenitor and into the myelomonocytic progenitor, we see all other white blood cells being produced through this line. Monocytes and macrophages, dendritic cells, neutrophils, eosinophils, basophils, and mast cells. Note that for this lineage, GM-CSF and IL-3 are required, and those are two things that you need to know. GM-CSF and IL-3 for all of the myelomonocytic lineage, and then going back to the lymphoid lineage, you need to know IL-7 being important in the development of T cells. So here we come to our first question of the day. A 3-year-old boy is discovered to have a genetic mutation that results in deficient levels of GM-CSF. A bone marrow smear would most likely show a deficiency in which of the following cell types: A, T cells, B, B cells, C, erythrocytes, D, megakaryocytes, and E, polymorphonuclear cells. The answer to this question is E, polymorphonuclear cells. We see that from the previous slide, you'll note GM-CSF was required for the differentiation of all of the granulocytes, including polymorphonuclear cells. Here we see a different view, again more simplistic than the last slide, but again important to note the differences between the lymphoid series and myeloid series of cells. So starting again at the top with stem cells of the bone marrow, then depending on what cytokine they see, they differentiate into either the lymphoid series or the myeloid series, cytokines IL-7 being involved in the lymphoid series, and again IL-3 as well as GM-CSF being involved in the myeloid series. The lymphoid series further breaks down into B lymphocytes, T lymphocytes, and NK lymphocytes, and the myeloid series breaking down into monocyte macrophage type cells, dendritic cells, eosinophils, and mast cells. Moving on, let's take a look at each of these cells on an individual level, starting with neutrophils. Neutrophils are the most abundant leukocyte or white blood cell that you'll find in the blood. They are also the first cell type to respond to infections. As part of the innate system, they're part of the immediate response. And the first cell you will always find in an acute inflammatory response is this neutrophil. Now, if you see high amounts of immature neutrophils in the blood, we refer to this as a left shift. If you can think of maturity along a spectrum, as the neutrophils are released into the bloodstream to finish maturing, when there's an infection present, the body wants to send as many neutrophils out into the blood that it can to take care of this infection. And so we call this a left shift. It will dump all of the neutrophils, even the immature neutrophils, into the blood. And the presence of this increased amount of neutrophils indicates that there's an infection. These neutrophils, once they're dumped into the blood, circulate, migrating to the different tissues, and then extravasate through the blood vessels and into the tissues to both undergo phagocytosis of whatever it is that's causing the infection, and also release inflammatory mediators to further enhance the immune response. These cells are rapid responders again, and their survival is very short, on the matter of days. They're often referred to as the pawn of the immune system, again because they're the first one that gets sent in, and also because they have a very short survival. They're intimately involved in acute inflammation and always used as a marker of acute inflammation, and also involved in pus. So if you ever see pus on the boards, then you automatically should think neutrophils or PMNs. And also they fall into the granulite lineage, as you can see in this picture. The many cytoplasmic granules that you see, these hold different lytic enzymes that are involved in breaking down extracellular pathogens. The next cell that we'll discuss is the monocyte and the macrophage. These are from the same lineage, and they're actually the exact same cell. The difference in name comes from where they're located. It's the largest circulating blood cell, and when it leaves the bone marrow, it's known as a monocyte. So it leaves the bone marrow as a monocyte, circulates through the blood for several days, passes into lymph nodes, and surveys for different pathogens or different other danger signals that it might be looking for. And then once it's gone through the blood for a number of days, it will migrate into the tissues. And once they get into the tissues, they change their names to macrophages. They take up residence in whatever tissue they migrate to, and they can live there for a very long time. One of the cell markers that they're known for is the marker CD14. So if you see CD14 on the boards, you should think macrophage. Now these cells can go by many other names, but the thing to remember is that they always have the same type of function. They're all macrophages. For example, histiocytes is another word for tissue macrophages. Kupffer cells are macrophages that are found in the liver. Osteoclasts we normally think of as bone cells, but what do? They break down bone, so macrophages. And there are many other macrophage types as well, but one thing to keep in mind is that these are all macrophages. They're all doing the same thing, have the same different characteristics. In this slide, we'll discuss the other granulocytes, eosinophils, basophils, and mast cells. You'll note that in each of these cells, they have those cytoplasmic granules, which is why they're characterized as granulocytes. On the left, we have the eosinophils, so named because of the red granulocytes that you see with H&E staining. These cells are known for their involvement in both allergic reactions and parasitic infestations. If you ever see parasites on the boards, think eosinophils. These cells have Fc receptors, which we'll talk about later when we talk about B cells. Other important points to note about the eosinophils is that they're activated by IL-5, and they also produce major basic protein, which is an acute phase reactant that is involved in acute inflammation. So again, eosinophils, think parasites, think IL-5. The next cell is the basophil. And with the basophil and the mast cell, we can kind of look at them the same way. They have the same function. The difference is where they're located. Basophils like to circulate through the blood. Mast cells like to reside in tissues. Both of them are known for the Fc receptors on their surfaces that bind to the Fc portion of the IgE antibody. And this binding is very tight, and it's intimately involved in the allergic reactions that we see involving basophils and mast cells. When we talk about hypersensitivity, you'll see this theme come up again. IgE binds very tightly to basophils and mast cells. Both of these cells are also involved in systemic histamine release, basophils on a systemic level, mast cells on a local level. And so with this histamine release, you automatically think vasodilation. And again, we can think of this in terms of an allergic response. With the mast cells, we can think of local histamine response. So again, think back to allergies, think to the nose. We have mast cells residing there. They release histamine locally, and you get the runny nose type of picture that you see with type 1 hypersensitivity or allergic reactions. Now the basophils, because they're circulating, we get more of a systemic histamine release. If that's the case, then what would you expect to happen? That's right, anaphylaxis, things on a more systemic, a broader scale. The next cell is the B lymphocyte, and here on the left we see a picture of a naive B cell or a naive lymphocyte. We see a high nuclear to cytoplasmic ratio, which is characteristic of all the lymphocytes, staining purple on an H&E stain. On the right we see an example of a plasma cell, and I bring this up because of the characteristic nucleus that you see. So if you see this type of nucleus, which is often called a clock face nucleus, or you might hear it referred to as a pinwheel nucleus, that's characteristic of a plasma cell. Now, what are B lymphocytes? What do? They mediate what we call humoral immunity, and we'll talk about that a little bit later on. These cells develop in the bone marrow, as do all lymphocytes. They also mature in the bone marrow. They bind unprocessed antigen with surface Ig. So these lymphocytes get out into the blood, and they look for antigen in its native conformation, which is important in distinguishing them from the function of T cells. They are activated with T cell help, however, with the exception of a subset called T-independent B cells, which are activated independently of T cell help. These B cells, once activated, will differentiate into memory cells and plasma cells. The memory B cells, remember, are involved in that anamnestic or secondary response that we talked about in the adaptive arm of the immune system. And the plasma cells are basically antibody factories, making different kinds of antibodies to combat an infection. Memory B cells, it's important to note, are also good APCs and function in presenting antigen to T cells. In this slide, we'll discuss T lymphocytes, and here we see a picture again of a naive lymphocyte that looks very similar to what you would see with a B lymphocyte, and in fact, in its naive form, on an H&E slide, you can't tell the difference between a T cell and a B cell, so you can only characterize them as lymphocytes. T lymphocytes are very different in function from B cells, however, and they're known as the generals of the adaptive immune response. They orchestrate all of the different cells that are involved in an immune response once they become activated. They're responsible for what we call cell-mediated immunity to differentiate them from humoral immunity, which is under the auspices of the B cell immune response. These T cells, although they're born in the bone marrow just as all other white blood cells, actually mature in a different organ called the thymus, which we'll talk about later. They recognize antigen that has been processed through a TCR-CD3 complex or T cell receptor CD3 complex, and the antigen that they recognize is broken down, differentiating it from the B cells, which recognize antigen in its native form. The T cells will only bind to antigen that's presented in the context of an MHC molecule, and again, this is where those antigen-presenting cells come into play. An antigen-presenting cell has to break down an antigen and present a small portion of it to this TCR-CD3 complex in order for the T cell to respond. There are two major types of T cells that we concern ourselves with. One is the CD4 positive or T helper cell. These cells are involved in producing cytokines that are involved in differentiating or making a specific immune response. And the CD8 positive or cytotoxic T cell lymphocytes are involved in killing cells that have either been infected or are cancerous. Antigen-presenting cells are the other important cell involved in T-cell immunity. Now, antigen-presenting cells, when we talk about antigen-presenting cells, we're talking about 3 cells specifically, and that's the macrophage, then dendritic cells, and the B cells. These are the only 3 cells that are involved in processing and presenting antigen to T cells. And these cells go around, they migrate to secondary organs such as the lymph node and the spleen, and they engulf, process, and present antigen to T cells. They use 2 different major histocompatibility complexes, class 2 and class 1, to present to T cells. And this is an important point in understanding how T cell immunology works, and we'll go over it again a little bit later. But if they're presenting antigen on MHC class 2, then they're presenting to CD4 or T helper cells. And antigen-presenting cells are the only cells in the body that express MHC class 2. So these are the only 3 cells that would present to CD4 positive T cells. Now, if antigen is presented on MHC class 1, then they're talking to CD8 T cells. And it's important to note that all nucleated cells, meaning every cell in your body except for the red blood cells or erythrocytes, express MHC class 1. So any cell in the body has the capability of presenting to a CD8 positive T cell, and that will become important when we talk about the function of CD8 T cells. So through this MHC complex presenting an antigen to the T cell receptor CD3 complex on the T cells, we get this conjugation being formed, and that's what will activate the T cell. Moving on, natural killer lymphocytes is another type of lymphocyte. However, it's different than being T lymphocytes in that it is not part of the adaptive immune response. Natural killer cells are part of the innate immune response. They don't have memory capability or adaptive capability that the T and B cells have. And what these cells do is they go around and detect low amounts of MHC class 1. They look at all nucleated cells and they decide if there's any cell that has downregulated its expression of MHC class 1. Now, why would a cell do that? Most likely because it's been altered, either because it's been infected or because it's been altered by some type of tumor protein. So the main function of NK cells is in recognizing this altered self cell and then being able to kill it. These cells are both granulocytic and cytolytic, so they have the ability to kill these altered self cells. They're activated by several different cytokines, general inflammatory mediators such as IL-1, more specific lymphocyte activators such as IL-2 and interferon gamma, and very specific to the natural killer lymphocyte is IL-18. So remember that one specifically for natural killer cells, IL-18. All right, another question. A 34-year-old man returns to his home in Miami after a week-long vacation in Mexico. Shortly after returning home, the man develops severe watery diarrhea. He admits to his doctor that he drank some tap water on his last day there. Stool studies are positive for Giardia lamblia. Which of the following cells will be most involved in the immune response? A. Monocytes, B. Macrophages, C. Eosinophils, D. Basophils, and E. Neutrophils. The answer is C. Eosinophils. Again, going back to the question stem, we see that the most important thing that you need to draw out of this is that it's Giardia. When you know that Giardia is a parasite, again, the bells and whistles should be flashing off in your brain. Parasite, anti-parasite response, eosinophils. Another question. A 14-year-old boy has been receiving inductive chemotherapy for precursor B-cell acute lymphoblastic leukemia, and his last blast count was none detected, indicating that complete remission has been obtained. His absolute neutrophil count was 489 per microliter. This morning he is complaining of shivering chills and is febrile to 103 degrees Fahrenheit. He rapidly becomes tachycardic and hypotensive with warm extremities. He is diagnosed with neutropenic fever and septic shock. Gram stain and blood cultures are consistent with Staph aureus bacteremia. The immune response involving which of the following is defective in neutropenic fever? A. TNF-alpha, B. IL-1, C. B cells, D. NADPH oxidase, E. pus formation, F. macrophage. The answer to this one is E. pus formation. And this is a good opportunity to step back and talk about strategy for answering these types of questions. So in reading this question, you get a lot of information that means absolutely nothing to the question. If you get down to the stem, the immune response involving which of the following is defective in neutropenic fever. That's really all you need to know. Again, neutrophils, pus. Neutrophils, pus. So if you see pus in the answer choices and you know that it has to do with neutrophils, there's your answer. All of the rest of this was just to kind of throw you off with a lot of big fancy words. So it's important when you start to tackle these questions, go ahead and look at the question stem. Find out what the question is asking, and then see if you need all of that other information. In this case, you didn't. Next, we'll talk about cytokines. So cytokines are soluble proteins that are released from white blood cells or leukocytes that communicate information via cellular surface receptors. This is kind of the mail system for the immune system, if you will. The cytokines are released by one type of cell, they get picked up by another type of cell, and the cytokines are directing the action. They're telling one cell what to do, what to be, how to act, that kind of thing. So what can these cytokines do? Well, they regulate cell growth and development. Cytokines such as IL-2, which can cause proliferation in T cells and B cells. They can activate and shape modes of immunity. They can help the immune system decide what type of immune response it wants to be, antiviral, antibacterial, antiparasitic. This is all involved in cytokines. It can act in an autocrine or a paracrine manner. It can stimulate the cells that are producing it as well as cells that are nearby. It can also act in an endocrine manner, circulating through the blood and activating faraway cells, and also have pleiotropic hormone effects in causing different activation status in different types of cells depending on the receptors that are being expressed and depending on the additional cytokines that are in the milieu of the response. And so again, taking a step back and looking at generative lymphoid organs, we can kind of get the whole picture of what's going on. On the left, we see that initial generation, the initial involvement of hematopoiesis and differentiation starting from the bone marrow or the hematopoietic stem cell. And then from there deciding, am I going to be a B lymphocyte or a T lymphocyte? Again, focusing here just on the lymphoid organs. If it's a B lymphocyte, then it stays in the bone marrow and it becomes differentiated and matures all within the bone marrow. If it's a T lymphocyte, then it's going to leave the bone marrow as an immature cell and migrate to the thymus, where it receives what we call thymic education, and we'll talk about that a little bit later. Moving on over to the right side of the slide, we see with the B lymphocytes, they leave the bone marrow as mature B lymphocytes into the blood, and from the blood they then circulate through the spleen and through the lymph nodes, things that we would call peripheral lymphoid organs, where it's involved in recognizing that native antigen. Again, remember that B cells like to recognize antigen in its native form. So it passes through the lymph nodes in the spleen, it will go back into the blood, and will just kind of circulate through the body looking for its specific antigen. If it doesn't find its specific antigen, then it will die by neglect. The T cells will do the same thing. They'll leave the thymus as mature T lymphocytes. They will circulate through the blood and lymph. They'll pass through lymph nodes and spleen and also mucosal and cutaneous lymphoid tissues, and then recirculate back through the blood and go and find another lymph node or more cutaneous lymphoid tissues that they will just circulate through, trying to find their match, trying to find the specific antigen that they're looking for. And again, if they don't find that specific antigen within a certain finite amount of time, then they will die by neglect. So in this process, we get a constant regeneration and renewal of the immune system with different B cells, different T cells, all looking for a specific antigen that might or might not be there in order to protect your body from foreign invasion. So here in this slide, we have a picture of the bone marrow. So from looking at kind of a macroscopic view or a low power microscopic field, we see different aspects of the bone marrow. We see the pink trabeculae, which is the site of bone formation. We see all those little white dots, which would be fat. Of course, it doesn't stain on an H&E stain. And then all the purple, everything that you see in between, that's the site of hematopoiesis. That's where all of the white blood cells are being formed. Again, on an H&E stain, if you're seeing purple, you should be thinking white blood cells. Again, another function of the bone marrow is B cell maturation, and we'll talk about that in the later lecture. And so here we see another close-up view, again with the pink trabeculae. You can see little osteocytes in there being involved in bone formation, which of course is one of the primary functions of bone marrow. And then again, in between these trabeculae, we see all kinds of different purple cells, and all of those purple cells should be screaming white blood cells to you. Some very specific things that you can see up in the top left, there's a granulocyte colony. You can see those purple cells that have maybe a reddish cytoplasmic tone to them, which would be eosinophils. In the middle of the slide, you can see a megakaryocyte, a big cell, which of course is a precursor to platelets. And then you can also see in the bottom right a red cell island. Remember that red blood cells are also made in the bone marrow, and you can see a little site of erythropoiesis there. So here we have a broad picture of the thymus. Again, remember that the thymus is the organ that immature T cells will be migrating to in order to receive their education. So we also can see a common theme throughout the immune system within the thymus, and I'll refer to this in some other slides as well, and that's the architecture that you see. Notice that you have this outer cortical layer, this outer cortex, and then as you move to the medulla, you see these circles. Now, whenever you see circles on an H&E stain within an organ, you should automatically start thinking of immune function. These immune cells like to band together in these little circular patterns that you see. So again, circular patterns like this, you should think that's immune tissue. Now, within the thymus, we have T cell maturation going on, what we call central tolerance being established. And this tolerance is established in two different sections, both positive selection and negative selection. So let me give you a brief overview now, and then in a later slide, in a later lecture, we'll come back to that again. With positive selection, what you're doing is making sure that your T cells will respond to your antigen-presenting cells. So positive selection, in order to pass positive selection, a T cell has to be able to recognize your own MHC. If it can't recognize your own MHC, then it will die by what we would call neglect, and it won't move on through the maturation process. So first thing we want to do is get rid of all the T cells that don't recognize your MHC, and as a consequence, don't respond to your immune system. So we get rid of all of those T cells in positive selection. Now in negative selection, the T cells we want to get rid of are the T cells that bind to MHC too tightly. And the reason for that is that if we get these T cells that like MHC a little too much, they may respond to an antigen that they're not specific for. And if they do that, then we could get a state of autoimmunity. That's not a good thing either, especially on a T cell level, because they activate all of the other types of cells of the immune system. So in negative selection, we want to weed out all of those cells. So any cell that binds to MHC too tightly gets killed by apoptosis through negative selection. So that at the end of the day, what we have is T cells that recognize MHC but don't bind to it too tightly. Those are the T cells we want circulating out in our blood. Those are the master T cells for our immune system. So with the bone marrow and the thymus, we would refer to those as the primary lymphoid organs, or the generative lymphoid organs. Moving on, let's discuss what we would call the secondary lymphoid organs, or the peripheral lymphoid organs. These are organs such as the lymph nodes, the spleen, the mucosal and cutaneous lymphoid tissues. And this is where the B cells and T cells go to work. If they're educated and mature in the bone marrow and the thymus, that's kind of like home for them. The peripheral lymphoid organs would be the job site. So it is within these organs that they optimize interactions of antigens, APCs, and again the B and T lymphocytes to promote adaptive immune responses. This is the site of antigen presentation. This is the site where all the cells come together and decide, hey, what am I infected with and what are we going to do about it? So in looking at the lymph node, here we have fluid from epithelia and connective tissue that's containing the antigens, and we call this fluid lymph. So as these tissues get excess fluid, either fluid that's leaving through the capillary base, if you remember from your circulatory lectures, or fluid that is caused because of swelling, because of some type of local inflammation, this fluid, no matter the source, is referred to as lymph once it's out in the tissues. And this lymph then will drain through the lymphatic system. As it drains through the lymphatic ducts, it will encounter lymph nodes. It will flow through these lymph nodes, and within the lymph nodes are different antigen-presenting cells, dendritic cells, macrophages that live there, that reside in the lymph nodes, that will pick up this antigen. Now, through the circulation, through the arteries, as we see here in the diagram, we have the T cells and B cells coming through what we call high endothelial venules. They will enter the lymph nodes, and they can establish residency there too. They might hang out for a little while, and they will go around and they will survey the land. They will go and they'll talk to the dendritic cells, they'll talk to the APCs, and they'll see if there's an antigen that's specific for them, and specifically referring to the T cells. The B cells, of course, will recognize native antigen. So if they're residing in the lymph node, they will pick up native antigen just as it is right out of the lymph. Now, if they happen to find their match, they will become activated. They can activate the other cells that are around them, and they can start an immune response. If they don't find their specific antigen, Then they can leave either through blood vessels or through the efferent lymphatic vessels, and they can move out into the peripheral blood vessels again and go find another lymph node or travel to the spleen or travel to other cutaneous tissues where they're going to again try to establish a site of infection, look and see, survey the land, see if there's something there that they need to respond to. So in this slide we have another diagram that we can kind of again see the architecture of the lymph node. And if you look at the cartoon diagram on top, we again see those little circles that I talked about. We have an outer cortical layer, and then as you move through, we see those little circles. And what did I say? Anytime you see those little circles, you got to be thinking immune system. Now, within the lymph node, we call these little circles follicles, and this is what we refer to as a B cell zone. This is where the B cells like to take up residence within the lymph node, and they hang out there waiting for the lymph to pass through, waiting to see if their antigen comes by. Now, within the follicle, there's a more concentrated area called the germinal center, and this is, again, another site of antigen processing. Now, moving down through the lymph node once you pass the follicles, immediately interior to that we have what we call the paracortex or the T cell zone. And as the name suggests, that's where the T cells live. So again, if a B cell living in the follicle, the germinal center, picks up its specific antigen, it can internalize that antigen. Remember, they can act as APCs. So they can migrate down into that paracortical zone and talk to the T cells, present antigen to the T cells, say, hey, I've got something going on here, and then the T cells can respond. They can make cytokines, they can establish an immune response. Other APCs, macrophages and dendritic cells, will do the same kind of thing. Pick up an antigen, migrate into that paracortical area, and present it to T cells. Now, activation results in formation of these germinal centers. As I mentioned, these germinal centers are kind of more concentrated zones of specifically memory B cells that like to be involved in that enhanced secondary response, which we'll talk about when we talk about humoral immunity. As they pass through the paracortical zone, going again more interior, they get into the medulla of the lymph node, and then passing through the medulla, they can exit either through the efferent lymphatic vessel or through the vein. Looking down on the bottom of the slide, we see an H&E stain or a cross section of a lymph node, and you can compare it to the diagram above. Again, you see those little circles, and within those little circles you see those concentrated circles, which would be the germinal centers, as part of the follicle. So again, circular patterns there, and we can see or assume that this is immune system or immune function. Moving on to the spleen. The spleen, as far as immunology goes, you can think of as a bigger lymph node. Instead of examining the lymph, instead of filtering the lymph, the spleen's more involved in filtering the blood. So, other than lymphoid function, the spleen also removes senescent red blood cells. So it actually removes white blood cells that are getting too old and red blood cells that are getting too old. It's involved in their breakdown and processing. Now, as far as antigen presentation goes, it's kind of along the same lines as the lymph node. It will trap blood-borne antigens by antigen-presenting cells, and it can present them to T cells. In the diagram, what we can see, there's a T cell zone called the PALS zone, and then there's the B cell zone, and within the B cell zone, lo and behold, we see again these little circular patterns, these germinal centers that can form. And then looking down below on the H&E slide, there again, we see the PALS, or the periarteriolar lymphoid sheath, where the T cells like to live, and the germinal center of the lymphoid follicle, where the B cells like to live. And just like in the lymph node, these B cells and T cells will talk to each other in order to form an inflammatory response. So this whole T cell, B cell zone, you might also hear referred to as white pulp. So again, white blood cells are purple on the stain. The white pulp looks purple on the stain as well. Now, outside of that white pulp, we have red pulp, and that's the site of red blood cell processing. Okay, we have another question here. 54-year-old man is involved in a serious car accident. Due to uncontrollable bleeding, the surgeon decides to remove his lacerated spleen. Which of the following will be decreased due to this surgery? A, antigen presentation, B, erythrocyte production, C, erythrocyte clearance, D, digestion of food, E, drug detoxification. The answer to this question is C, erythrocyte clearance. Going back to the question, we see that this is involving the spleen. So understanding of the spleen function and its involvement in filtering and clearing out red blood cells, helps us to answer this question. Another question, a 19-year-old college student comes to the health clinic complaining of fatigue for the past week. He says that he has also had a sore throat and mild fever to 101 degrees Fahrenheit. His girlfriend has had similar symptoms. On physical exam, you would expect to observe cervical lymphadenopathy, and which of the following? A, positive Murphy's sign, B, psoas sign, C, hepatosplenomegaly, D, pain at McBurney's point, or E, costovertebral angle tenderness. And here the answer is C, hepatosplenomegaly. This clinical scenario is one of mononucleosis or EBV infection. We see a college-age student, sore throat, mild fever, girlfriend with similar symptoms. This is infectious mono. So on physical exam, think of what you're going to find. Tonsillar exudate, cervical lymphadenopathy, and the other part of the triad is enlarged spleen. Now it's important to note and remember as doctors that this can be very dangerous for people with EBV or mononucleosis. You have to watch that spleen because sometimes it can get so enlarged that just minor traumas can cause rupture. Lastly, we have the mucosal lymphoid tissues, and you'll notice that all of these end in ALT. So anytime you see something ending in ALT, that stands for associated lymphoid tissue, and it's found all throughout the body. If it's in the gut, it's called gut-associated lymphoid tissue, or GALT. If it's in the bronchus, it's called BALT. If it's in the nose, it's called NALT, and so on. You get the idea. So anytime you see any of these things, again, you're thinking lymphoid tissue. It's just like a lymph node, but instead of having its own discrete architecture, it's found as part of another tissue. And so looking at these slides, you can see these are mucosal types of tissue, but if you're looking within the mucosa, what do you see? There they are, those little circles. Remember what we said, anytime you see those little circles, be it in the spleen, the lymph node, the intestine, the tonsil, wherever you see it, you see those circles, think immune system. This concludes our general overview of immunology. In the next section, we'll cover the barriers of the innate immune system.